We are now going to dive deeper into how to best manage frailty. So, what does frailty mean for the healthcare team? First, we must recognize that frailty is a distinct physiologic syndrome in older adults, not synonymous with old age, disability, or comorbidity. The central features of frailty include weakness, poor endurance, and slowed performance, which are all modifiable with therapeutic interventions, and therefore, frail older adults should be referred for rehab and fall prevention interventions. Targeting frail older adults may potentially reduce the incidence of falls, hospitalizations, worsening mobility in ADLs, and mortality. For those who meet 3 or more of the frailty criteria, the challenges in care include the organization and sustainability of the continuum of services, resource allocation, and cultural competence in service delivery. Creative solutions include intensive care case management programs, targeting at-risk older adults, partnerships with families, enhanced use of telemedicine and assistive technology, and promoting healthy aging. Nurses and therapists have the potential to improve elder health across settings through clinical practice, education, leadership, and research. Management of frailty. Evidence-based treatments for frailty include exercise, caloric and protein support, vitamin D, and reduction of polypharmacy. Strategies and goals for care. Avoid unnecessary admissions to the hospital or long-term care facilities. This is something that OTs can have a direct impact on. Think about all the interventions, all of the education we can give individuals to prevent them from being readmitted. Maintain functional independence, another key thing that OTs do, right? That's the whole definition of our role on the team. Early identification and management of frailty. Deprescription of unnecessary medications. Now, this specifically, we are not going to be telling individuals to stop taking a medication without a doctor's permission. However, it is something that we can speak about with individuals if we're going to do medication management with them as an IADL, and we see that they have 5+, 10+, 15+ medications that they're taking, we can pose the question, have you discussed if all of these are still necessary with your, physicians, with your team? Maybe some of them weren't. Maybe they had an acute episode of some type of health concern, and now that medication is no longer needed. And then, of course, first-line therapies, promoting physical activity and adequate protein intake. Incorporate an individual's preferences, priorities, and psychological resources into the care management plan. Right? It's so important that someone is psychologically ready for the interventions that you're giving them and that they're understanding why they're necessary. This is going to 100% improve adherence to your therapy protocols. If someone doesn't understand why you're giving them something to do, they're not going to have any follow-through. So promoting activity. Delay onset of frailty by promoting participation in health promotion and wellness program and increasing physical activity and exercise. All members of the rehab team should be promoting increased activity, connecting patients to rehab services and community resources that can help get them at the low physical activity, out of the low physical activity criteria. A recent study in the 2019 Journal of the American Geriatric Society found moderate positive effects of individualized multi-component exercises at moderate intensity, that they had a positive outcome to prevent falls and reduce frailty and lower mortality in long-term care residents. It is definitely a need to identify at-risk and frail elders, delay and prevent adverse outcomes with targeted interventions for strength, endurance, and functional mobility. What can rehabilitation do, right? This is our role. It may reduce dependence and the frailty state. It's most helpful in addressing strength issues and decreased function. It's thought to be helpful for individuals pre-procedure or pre-surgery. It's thought to be less beneficial for those who are already considered frail, even though it is not beneficial to those individuals, or individuals who are cognitively impaired. Again, this does not mean that it's not beneficial. It just means that it's less beneficial for those individuals. It takes a village. Frail older adults often need numerous healthcare services across the continuum of care, thinking about everyone on the interdisciplinary team: OTs, PTs, skilled nursing, Meals on Wheels, home healthcare aides, nutrition management, and ongoing management of both acute and chronic health problems. Frail older adults potentially require a constellation of health services addressing both acute and long-term needs. Inpatient hospital services concentrate on acute and serious illnesses and injuries, while outpatient clinics provide ongoing management of both acute and chronic health problems. Long-term care primarily addresses functional needs of older adults and includes the system, financing, and delivery of a variety of community-based services. In addition to housing in the form of skilled nursing facilities, assisted living, retirement housing, and adult family homes, long-term care services also include adult daycare, home health and home care, wellness and health promotion programs, information and referrals, durable medical equipment, transportation, and meal programs, like I mentioned, Meals on Wheels. Other considerations we have to have for frail older adults. Consider the potential burden of labeling an older adult frail. Older adults may consider frailty as irreversible, which is not true. Frailty should not prevent access to appropriate interventions due to ageism. There's low research evidence currently for interventions of frailty. This is why we need to document well and create evidence-based research for what we're doing for these individuals. Occupational therapy interventions. Scoping review findings of community dwelling frail older adults. OT interventions include focus on standalone interventions as part of multidisciplinary approaches, recommendations and training in the use of assistive devices and adaptive equipment, ADL and IADL training, and home modification recommendations. These are all things that you're already doing as OTs and that you've already learned about in your education. Now just applying it to this specific group of older adults who are considered frail. In summary, frailty is a major problem with adverse outcomes. It may impact physical status, functional status, cognitive, and psychological well-being. It can be prevented if identified and addressed. It is multifactorial and needs multi-interventional approaches for management, including physical activity and nutritional management. Aging does not automatically descend towards frailty. Frailty is a condition associated with aging, but is not synonymous with aging. Criteria for frailty proposed by Freed is distinct from disability and comorbidity. Several members of the interprofessional team can assess and identify frailty, such as gait speed, activity levels, strength, and complaints of fatigue or weight loss. We need to consider the impact of the psychological factors and the cumulative effect of frailty. There is overwhelming and compelling evidence regarding the role of activity, exercise, and nutrition in preventing disability in frail older adults. Frailty is a syndrome associated with marked weakness, slowing, decreased energy, lower activity, and when severe, unintended weight loss. On the next slide, there's a clinical presentation of frailty. I want you to take time to look at these two patients. They're both 79-year-old men. I want you to look at these two courses of treatment or courses of medical incident. Why did these two men have very different hospital courses? I want you to review this and come to class prepared to discuss. On the next two slides are your references for this entire lecture. Thank you.